Thank you, Dara, very much indeed. It's a real pleasure to be here. Anybody knows anything about Boston weather, you know I actually want to stay here for the next month. If we get 3.7 more inches, we'll beat the historic record of the most snow in any winter. I'm praying for that because I want to be able to, I was telling Clare earlier. So today I'm going to try to walk through a review of prostate MRI, the sort of the state of the art, have a few disclosures, some NIH support, and just explain to you a little bit about the program and the research that we're doing at the Brigham Hospital in Boston, where we have the National Center for Image-Guided Therapy, which allows us to do some very cool, innovative work. That's the P41 team there, those people's names. We collaborate, of course, with our colleagues in urology, radiation oncology, medical oncology, and pathology on much of the work that you'll see here today. We have a collaborative grant with a group at Queen's, Acoustic Medical Systems, which are people who design software for radiation oncology, Johns Hopkins and WPI, and some robotic pieces. And so bits of this will move in and out, but I'm trying to keep it fairly clinical and focused. And the role will be to sort of define how it might work in your clinical practice, a little bit of an update on how we do it. I promise I won't get too technical. I'm going to keep most of the MRI lingo stuff till it's this afternoon's talk, but you will hear the word TR and diffusion and EPI and things like that a bit. And then about the current explosion in the interest in MR-guided prostate biopsies, what they mean and how they might play out in clinical practice. So the role of prostate MRI has really evolved over the 26 years. I think I started doing it back in 1988, where we started primarily in the staging business, so trying to determine was there a cancer outside the gland, had the tumor spread. And now you can see sort of a dizzying array of clinical scenarios where prostate MRI is being used today. Certainly the pre-biopsy screening one is certainly the newest on the block and the most controversial perhaps, and clearly completely unproven at this point, but something that's being done in trials in Europe and other places. Clearly to help in patients where there's been a negative trust-guided biopsy and repeatedly rising PSAs. I think MRI is well defined in that role at this point. Active surveillance patients, Lori Klotz and others are doing trials in their patients to see, can MRI replace the repeated biopsies in that scenario? Could you do biopsy, MRI, as you follow a patient instead of biopsying them repeatedly? Pre-therapy, pre-all therapies, pre-radiation, pre-surgery, pre-focal therapy, and then for monitoring afterwards. In patients with biochemical failure, is there a localized recurrence within the prostatectomy bed, or is there tumor elsewhere? The current state of the art is to get these three sequences, which I think all radiologists doing prostate MRI today will be doing in their clinics. The three sequences in order of importance are diffusion, T2, and dynamic contrast enhanced. If your patient has renal failure, can't get the gadolinium, don't despair. The first two are very good and will give you pretty much everything you want without the intravenous gadolinium. Many people suggest we may even stop doing that at some point. But these are the sort of quality of images you get below here, and I know you're familiar with prostate MRI, so I won't belabor the normal appearance. I just want to highlight, if that magnification works, that you can see the BPH nodules inside the prostate here, and if I can get my little arrow to work, see the normal encapsulation of normal hyperplastic nodules. This is a very important area that we've learned to understand, and we still struggle with in determining whether there's a cancer in the transition zone in the central gland. And these features are things to focus on in the normal situation. Cystic BPH, the sort of stroke, the glandular area, the calcifications. BPH is a heterogeneous disease, as you know. And this slide, of course, is obviously very familiar to all of you in the standard workup of a man with prostate cancer. Where does the imaging fit in, and where do we do it, and when? And some people are suggesting it might come here or after the first biopsy or at some point in treatment, as I just mentioned. These three sequences provide different information, and when we look at the tissue, MRI has a way to interrogate the tissue to understand pathologically what's going on. The T2 weighted images allow us to see the substructure of the prostate, to see the peripheral zone, the central zone, the transition zone, and the substructure, and of course cancers as focal low signal intensity masses, a gray area against the white background. It's easy to see in the peripheral zone. It's not so easy in the middle. The diffusion sequence, the one that everybody's excited about and has really exploded and taken the MRI techniques from where they were 10, 15 years ago to where they are today, and really in the last 5 years, every month there's a deluge of papers that are coming out describing the value of this sequence. So what's it all about? What's it trying to do? It reflects cellular density. And prostate cancer is a highly cellular, dense, packed tissue histologically. So if you think of an advanced prostate cancer, one that has a very high Gleason, you're going to have a very tightly compacted tissue with a lot of cells all close together. And that's what it's reflecting. And an advanced clinically significant cancer, when I use that term, I have a slide about that later, but that definition, as you know, there's no standard definition of clinically significant prostate cancer. But in general, for imaging purposes, it means a cancer that we believe has an element of Gleason 4 disease in it. And that's really where we're trying to tease these things apart with the imaging. And this, when you get the white appearance, this high signal on the DWI raw image, and the corresponding black, so it's the white-black combo on the ADC image, that's compatible with cancer, and that's compatible with a Gleason, probable Gleason 4 within that lesion. And it's reflecting the cellularity at that level. And that's pretty much what the literature is coming out to talk about. The vascularity, of course, is what we're looking at with dynamic contrast. We inject the gadolinium, we scan very fast, we get this little dynamic video clip that you can see in the bottom left. And if you watch the femoral arteries, they go white at the same time as the lesion inside the prostate at 5 o'clock. And so therefore it's arterially hyper-enhancing, very fast, sucking in the gadolinium, and that's classic for a cancer in the prostate. So here's the summary of those findings on T2 all across the top. T1 weighted images will not show anything on the pre-contrast, but show beautifully the edge of the capsule, the neurovascular bundle, so a good sequence for staging. Also very important in a patient who's had a previous biopsy, because the T1 weighted images will show focal hemorrhage. And hemorrhage can be a little bit of a confounder. You need to be able to map that out, so T1 is helpful. And there's the ADC showing a very black, very low signal lesion. And that blackness, the darker it is, the lower the ADC, the higher the Gleason grade, and I'll show you that literature in a few minutes. So here's a nice representative case, I think, which was loaned to me kindly by Francois Connu from Paris, and you can see multiple images of the same slice of a man with a large prostate, very thin peripheral zone, very heterogeneous BPH central gland, and if you look at the 3 o'clock location on all these sequences, you're going to see an image that shows the findings of cancer. This is on T2, here we have the ADC, and we have the DWI, and then we have gadolinium contrast enhanced, and then these color maps are what is extracted from a software program that does what's called pharmacokinetic analyses. Same program that's used by people in breast MRI and brain tumor imaging, looking at the flow of the gadolinium in and out. And the color extracts features that are related to the microvessel density. So at 3 o'clock you can see that. The man went to prostatectomy, and here's a nice slice showing us that tiny focal cancer sitting there at 3 o'clock. So these small lesions can be picked up. So this is the more technical stuff, which I'll skip over quickly. 1.5, 3 Tesla, e-coil, no e-coil, significant debates, unending debates in the radiology community, in your community. To be honest, whatever works at your hospital, whatever you can do, and however you optimize what you have, do it. There's no golden, you must do this. And I've just concluded a stint on the PI-RADS committee, which I'll talk a little bit about in a few minutes. It's an international working group of us who've come together to define some of the standards around prostate MRI. And PI-RADS has just been released last November. Says that 1.5 or 3T is fine, e-coil or no e-coil is fine. So we didn't come down hard and say you have to do 3T with an e-coil, which is probably the state of the art and the most advanced and the most high res and the way to do it. But it's not necessary in all scenarios. So I can talk about that subject for hours, as you can imagine, but I'll skip on. The T2 weighted sequence, the details are here. That's the normal. There's the abnormal. And that's what the abnormal tumors look like inside the middle of the prostate in the transition zone. Now look at the difference between that red, the stuff inside the red circle, and the one above. People have called this the charcoal sign, the smudged fingerprint sign. We all know what a fingerprint, when it's done right, looks like, and we know what it looks like when you've smeared it. So look at the top, you see the crisp edges and borders of the BPH, and down here you see none of that. It's completely obliterated by the aggressive cancer in that space. And the same patient, you can see now on the diffusion image, the corresponding white-black finding of the raw DWI and the ADC. And so this is really helpful. Diffusion imaging, I can go and talk about this. It's reflecting the local Brownian water motion, the cellular density. When the cells are very dense in that voxel, there's no room for the water to move. The water is paralyzed and it's restricted, and therefore it goes down. The signal drops down completely. So over the last several years now, several papers have come out correlating this ADC value, which is now a quantitative metric. Think of it as just like a Hounsfield unit measurement in a renal cell cancer on CT, but it's you drop your ROI on that, you come out with a number, and that's been correlated against tumor Gleason scores. And there are multiple papers now showing in these nice box plots how there's an inverse relationship between ADC and Gleason. As the ADC goes down, the Gleason goes up. So you can see here that as the ADC goes down, we get to this is the Gleason 9s, 8s, 7s, and 6. And this is from the group of Peter Pinto and Peter Choyke at the NIH. And some of these papers have been coming out over the years. And there's that case that I just showed you a minute ago, very black. So it would be over here with an ADC in the 800, 600 range down here. And these numbers will vary from one magnet to the other. So it's not really a specific number. It's more a little bit like the Hounsfield units in CT, where you say it has to enhance by at least 20 Hounsfield units. So this drops down, and anything below an 800 is a lesion that I would be very worried about. So here are two men from that paper from Peter's group, both with cancer, biopsy-proven cancer. And you can see there's a significant difference in these two patients' prostate ADC maps. From the back of the room, I suspect you can see very clearly that big black blob in the middle of that one, as opposed to this patient, where it's really hard to see much of anything. It's a bit gray over there. They put a cursor on it. I'll bring up some numbers in a minute. But just looking at it qualitatively, it's clear there's a big difference between these two men, the left one being bigger. So as expected, the ADC on the left side is very low at 670, and he has a big Gleason 8, bad tumor. On the right, Gleason 50, or ADC 1500, Gleason 3+3. And this is typical, because really there's not much to see in there. It's hard to know where to put the cursor. So this is a 3+3 tumor. And most of the literature now supports the diffusion as being the best sequence to really help us detect and characterize prostate cancer. This is a meta-analysis, and this is the ROC curve here for the diffusion-weighted imaging. We've done some work in our site demonstrating that with biopsy results and pathology results from whole mount prostatectomy, and you can see again we're getting fairly good ROC curves for the ADC and pretty good for one of the parameters in the dynamic contrast enhanced sequence. So PI-RADS is stands for Prostate Imaging Reporting and Data System, and this is something that radiologists developed back in the day for breast imaging. There's a thing called BI-RADS, BI, BI-RADS, and then there's LI-RADS, LI, LI-RADS. So these are ways for us as radiologists to determine a lexicon of terms, a standardization of techniques, and a way to communicate our results in a uniform fashion to you and to our clinical colleagues so that we all know that we're speaking the same language and that we've got a scoring system that we can define the likelihood of aggressive cancer. So this is the summary of what PI-RADS tries to do. To establish minimal acceptable techniques, standardized terminology, facilitate the use of data in a biopsy. And believe it or not, we've drawn up this templated map of the sectors of the prostate. And when I started doing prostate imaging back in whenever, there was two parts to the prostate. There was the peripheral and there was the middle. Now there's something like 36 different parts. Now, we all think that's, of course, a little nutty, but when you come down to thinking about it, we have to get precise about locations. We have to be careful about where we localize for either a biopsy or focal therapy or for radiation delivery. Communication of precise locations is really important. And many of you know that when you get back prostate biopsy reports, certainly south of the border, it may say the cancer's on the right or on the left, and that may be all you get. So you're left with this dilemma. Where did that biopsy core come from? How do I know where the cancer is if I'm going to do something focal? If you're taking the prostate out, it doesn't matter. But, you know, it's for some of the other therapies and some of the things that I think we're going to see and need more in the future, this mapping will be important. And this will be all embedded in software programs, so we'll basically, as radiologists, click on the little area where we think the cancer is and localize it very precisely for everybody. So to facilitate for biopsy targeting, and for assessment categories, to summarize our level of suspicion of clinically significant disease. And I'll come back to this in a minute. So we're assigning a score, a numerical score from 1 to 5 in each lesion we see, and determining whether a 5, of course, is an aggressive cancer or highly likely to be cancer, a 1 is a benign normal. And then we can talk about the problems in the middle, but that's the summary of that for the moment. Data collection, outcomes, education, communication, obviously all of those good things that we all want to do. So a 1 is a very low, clinically significant disease, highly unlikely, and 5, as I already mentioned. Intermediate, one of the most problematic groups here where it's equivocal. You can't really tell. And so this 5-point scale will be assigned for each lesion based on the T2 and the DWI. And in diffusion image, in contrast enhanced, It's changed now from PI-RADS version 1. There was a version 1 released by the Europeans in 2012. They put the DCE on a 5-point scale as well. We've decided that that's too complicated. We don't need to do that. The DCE is either it's enhancing or it's not enhancing. So it's positive or it's negative. And then you come with this final score. We don't summate them, so we don't end up with a total of something out of 12. It's basically one number for each lesion based on your overall impression. So you will know this better than I do, but clinically significant disease, obviously, in English language, that means disease that matters, disease that might need to be treated. And many people, of course, believe that's what we should be focusing on, not on the indolent, small volume, low volume, 3+3s, which were probably better done with active surveillance. But there are many definitions in the literature of what is clinically significant disease. It was nicely summarized in this paper from the UCL group, where they tested the MRI techniques against those definitions. And they did a nice job using 1.5T, no E-coil MRI, and compared it to templated saturation biopsies. So they prospectively compared the two. The MRI was done without informing the biopsy, obviously, because the biopsy was doing 5mm incremental grid biopsies all the way across the prostate, and taking each of the definitions. And certainly this is the most advanced one, the one that's really the most, nobody would disagree that this is clinically significant disease when you have a big tumor with a Gleason 4/3 and any core length, cancer core length of 6 or greater. That's real disease. And you can see how well the results turned out for the MRI. They had a greater than 95% negative predictive value. Sensitivities, depending on who the radiologist was, there were 3 readers. It went down to 63 in the reader with the least experience, but 84, sensitive 0.84. And then specificities, a little bit lower, but it's 0.6. And then, as I said, the negative predictive value and areas under the curve, pretty good. And so those are 2 independently prospectively performed studies. So I think that was fairly convincing. So now let's just talk a little bit about clinical scenarios where it's being used. In the active surveillance population, one of the nice things is that one can sample the prostate in a specific location and then repeat the biopsy or the MRI as needed to the same location each time you do the biopsy. So you're tracking change in an individual lesion. You can also supplement, of course, with a biopsy of anywhere else in the prostate that may appear obvious. And so the Memorial Group obviously supporting that in that statement there. Here's a nice example of a case from our site where we had a patient that we scanned in 2009, a perfect candidate for AS. He had a low PSA, low volume disease, only 1 out of 6 cores, but he had a visible lesion at that time. And interestingly, I'm not sure now that if I saw that guy today, as he would present, that I would agree that he should go on active surveillance. But anyway, he did, and we went until 2011. We repeated the MRI when his PSA changed, obviously went from 4 to 6. And you can see that lesion now, significantly larger and significantly lower ADC. So things have progressed here. Something's happening to that lesion. And you can see that we reported this out with decreased ADC and the lesion had increased. We recommended that they seek confirmation of what's going on in that area and suggested that the patient stop AS and go to treatment. And the biopsy came back with Gleason 3/4, but pretty high volume in 2 out of 8 cores. He did go to surgery and he had a confined 2.4 centimeter tumor inside the transition zone. Another example of a patient who was about to go on an AS protocol. His PSA had been rising until 2013. He had a biopsy in January at an outside hospital. Gleason 6 was found. But then very quickly, for one reason or another, he had another PSA. It bumped up to 12, and there was a concern that something was happening. So what to do next? Obviously, the choices are 3. We believed that he should have an MRI. He came in and had this MRI. We found a lesion on the T2 weighted images. It's easier to see here in the diffusion because diffusion works beautifully in the peripheral zone, better than the T2s. And you can see this area of white and black. So the white-black combo here again, demonstrating a mass with restricted diffusion on ADC 800. He went back to his urologist who did a cognitive, sorry, I have a few more images first, just to show you the dynamic contrast enhancement here in that area. You can see at what we call a type 3 curve, classic for cancer. He went back to the urologist who did a cognitive targeted truss biopsy, having seen the MRI, knew where the lesion was, easy enough to access with truss, and found a Gleason 9 in that lesion, and the patient then went on to surgery. So here's a place where it plays a role in the entry into an AS protocol, determining is this man really a good candidate to be on AS, when there was some sort of quirky thing with the PSA obviously going up. Another common scenario, I showed this to the residents yesterday, and they immediately recognized this clinical scenario and saw the lesion beautifully. But let me show you. A 67-year-old man came in with a PSA. Had been going up, has had 2 biopsies, both negative for prostate cancer. The rising PSA, and as Jerry Ritchie, my urology colleague in Boston, says, this is prostate-specific antigen, also known as patient-stimulated anxiety. When you have this scenario where it's gone from 6 to 17 and you still can't find a cancer, as we discussed yesterday, the people are tearing their hair out. So here's his MRI. And some of you may not have seen these areas before, but now you can clearly see a big lesion up here. This is the classic scenario that unfortunately trusts will miss, is the anterior lesions at the 12 o'clock location. And you can see it on the T2s here, the diffusion here, the contrast here. All 3 sequences in concordance. They agree with each other. Improves my confidence level in my reporting when the 3 of them are saying the same thing. I don't like it when they disagree. I always have to scratch my head a little bit. So if I did PI-RADS on this case, this is how I would report it out. If I had the software, I don't have this. This is just artificially done for my slides. I wish I had this in my PACS workstation. It would be wonderful someday, I hope. And then you would code it as a 5, because this is greater than 1.5 centimeters without definite extracapsular in this case, but you can show the lesion where it is so that it can be sampled by biopsy in whatever format is available. And now I'm getting stuck, so let's see. Stick it there. Good. All right, so we did a biopsy on him. In our program, we have an in-bore MRI-guided transperineal biopsy program. We have the ability to have MRI availability for this through our National Center for Image-Guided Therapy, which I'll show you some details about that in a minute. But we do transperineal in-bore biopsies, and the needle was guided directly to that 11 o'clock location. Transperineal there's no problem with biopsying any part of the prostate. You can get right up anterior. It's a straight shot in. It's obviously a little safer on the sepsis side. There's no risk of infection apart from the skin, which we clean, of course, and he had a Gleason 4-3. Staging. Let's shift a little bit now to the role of MRI in staging prostate cancer prior to therapy. This is a patient that was a patient of Jim Hu's when he was with us, who was planning to go to robotic prostatectomy, and he had known biopsy-proven cancer. And these are scans. I've sort of tried to put a few maps here so you all get anatomically oriented. We're deep down here at the apex of the prostate, just coming out of the gland into the sphincter, and we see a large tumor extending around to the left side here, and with evidence of extracapsular penetration posterior and inferior to the prostate, and also involving the sphincter. So he canceled his surgery, decided it was too high risk. The man would be likely to be permanently incontinent, of course, if one was going to have to go deep down and get a negative margin. And as you know, this is a site where commonly positive margins will occur, and so he went to radiation. Staging, seminal vesicle invasion. MRI can demonstrate this in 2 ways. Low signal intensity tumor extending upwards into the high signal normal seminal vesicle, which is normally filled, as you know, with fluid, and then it's dark black when the tumor comes in. And it also will enhance when you give the intravenous gadolinium. So you see a solid tissue sitting where fluid really should be. And so this is seminal vesicle invasion. And here's a patient who has both extracapsular and seminal vesicle invasion. Small area of extracapsular back here at about 6 o'clock on the image there. You can see thickening of the capsule, corresponding lesion on the ADC, and the ADC will show the seminal vesicle invasion as well, with a fairly extensive amount of it there. So high-risk disease. Post-procedure, rising PSA, a biochemical failure, and this was in post-prostatectomy. Patient who had a significant amount of prostate disease left behind, and you can see a large mass, 2 centimeters, in the prostatectomy bed. This was in the early days of the introduction of the Da Vinci. Those of you who were on that learning curve have gone well past that now, but in the beginning, obviously, without the haptic feedback and the ability to know where the prostate ended, this unfortunately was relatively common in the day. I don't see this anymore. So one of the things that we're doing is sort of as a research project with Adam Keibel, our chief of urology, is to provide him with this kind of information before the patient goes to surgery. Junichi Takuda is doing what we call segmentation inside the 3D Slicer, which is an open source software tool, which if anyone's interested could be used here. And I know Tim and his group over at BME are using Slicer for many, many things. But what the radiologist can do is segment out the tumor, show the relationship of that given tumor to the closest neurovascular bundle, to allow for surgical planning, and then display that data in some form of the visual field for the surgeon during the procedure. And that I say some form because we've tried with Intuitive to do things like demonstrate this holographically, put it in as overlays in the operating room, and they're helping us out with that. And I think the very nice project I've heard that Dr. Black is working on with the ultrasound here is very exciting, and a similar vein of sort of investigation that we're interested in is try to inform and enhance the information during surgery. What we do at the moment is to bring a laptop to the operating room and show this in 3D to the surgeon as he's doing the surgery, so he can determine the proximity of the neurovascular bundle to that given tumor. And it's worked out quite nicely. An interesting little small project that we've done with one of the residents in urology is looking at the external urethral sphincter volume and also its location, how much of it is inside the prostate. As you can imagine, the more sphincter that's in the gland that gets removed, the higher the rate of likely incontinence after surgery. And so we've been able to demonstrate that in a very small group. We presented this at SUO last year, showing that with significant difference when the ratio of extraprostatic to intraprostatic was associated with a higher rate of incontinence when the more of the volume is inside. So we see the sphincter very well on MRI, and you can determine the volume of it. So now I want to shift gears just a little bit into the intervention field and tell you a little bit about what goes on at the Brigham, what we have there that's a pretty unique facility that we've fortunately been able to build and operate based on NIH funding and hospital funding. We have a suite that we call AMIGO. AMIGO stands for Advanced Multimodal Image-Guided Operating Room. We have 3 rooms in this suite which contain in the middle a fairly standard but not standard operating room, but operating room table standard. We have on the left side of it a PET CT scanner, and on the right side an MRI scanner. And the MRI scanner is integrated by Imris, a Canadian company that takes the Siemens magnet off the floor, puts it on huge railings on the ceiling. You're probably familiar with this from neurosurgeons using it, and it moves the magnet in and out of the room as needed during a surgical procedure. Many of these have been installed across the world for neurosurgical procedures, so we are using that in many, many different ways. And so these 3 rooms are sort of modular separate rooms where potentially 3 cases could go on at the same time, or 1 case where a patient might move between 1, 2, or even 3 rooms, depending on the clinical needs. And this goes back way back to the beginning of the Brigham itself. My colleague Frank Jolesz established an image-guided therapy program there where we had what was called the MRT, or double donut magnet. He was a neurosurgeon in Hungary who came to the Brigham and became a radiologist, and this was designed to help neurosurgeons see the brain tumor, understand the extent of brain tumor in surgery with open craniectomy, and have imaging available at the same time. And so this device was developed for that. Anthony D'Amico, my colleague in radiation oncology, and I developed a brachytherapy program inside that device where we did MR-guided prostate cancer brachytherapy, insertion of seeds under MRI guidance for many years. This system subsequently, unfortunately, didn't last because it didn't have a long-term viability in the market. It wasn't useful for people beyond doing interventions, and there really was a very much of a niche or a boutique operation. We also do a lot of work in MR-guided focused ultrasound that you may be familiar with, a group in Toronto now with Clare and others are leading this effort in Canada. And in Boston, we continue to do this with Nathan McDonald and a company called Insight Tech. We use MRI-guided focused ultrasound to treat uterine fibroids, bone metastases within the brain for relieving tremor. It's a very exciting thing. It's beyond the scope of this talk today, but happy to talk to anyone afterwards. In 2005, we established what is known as now the National Center for Image-Guided Therapy, which is an NIH-supported investigative group. And in 2011, we opened this suite. The group that works in the research there is led by Frank and myself and Tina Kapoor and others. We have 2 clinical programs in prostate cancer and 1 in neurosurgery, and it's supported by a lot of investigators who do a lot of work similar to the group at BME here that Tim and I visited with Tim yesterday, looking a lot at image processing, engineering, robotics, biomedical engineering, and a lot of tools that enhance and hopefully enable and facilitate surgery. This is a photograph of Frank, who got an Innovator Award for that. And then some nice fancy pictures of the room before it actually started being used, when it was clean and brand new. so sparkling floors. You can see from here, we're looking from the operating room through the door into the MRI scanner, the table, and then the magnet itself will move in. The operating room suite is equipped with a cone beam CT, ultrasound, and a bunch of other companies listed here that we work with on testing equipment. It's sort of an R&D space that is so much fun to work in. We have a lot of challenges, but a lot of really exciting, innovative stuff coming out. So we're doing work, and I won't go through all of this because you're a urologist. You don't really want to hear about breast cancers and brain tumors, but we do a lot of work in other areas. And in the prostate, we've been doing our biopsies in this space because we have the funding from the NIH to do that. And then if you're interested, this is an array of some of the kinds of cases that we're doing in there. They're all clinical cases. They're all patients who are having standard of care plus surgeries and treatments, all of which involve some level of imaging and new innovative approaches. So in the prostate, we've had a program looking at detection, biopsy, staging. As I've mentioned already, we did brachytherapy. We're using the MRI for treatment, and we're developing a robotics program. So in AMIGO, the two big programs we're working on at the moment are biopsy and focal therapy, integrating the slicer, doing biomarker validation. And when I say that, what I'm talking about is validating the tissue in the MRI image with a voxel correlation with a biopsy core. We have a new program where we're hoping to integrate genomics into that core analysis as well and allow us help predict, hopefully based just on a biopsy, the genetics and the imaging of that patient. And so this is just a big picture overview of a lot of the stuff that's going on in there. We're doing focal cryotherapy. When you do cryotherapy on MRI, you can actually see the ice ball as this big black area in the image, and you can determine the margins of where your cryotherapy has gone in 3 dimensions. We have a robotics program which is trying to help extend the physician's arm and enable more precise needle placement in the bore of the magnet. One of the things we're very aware of is that the prostate moves during imaging. It deforms when you put a needle into it. A lot of things happen to the prostate during procedures that we have to understand. So we've been doing biopsies for a long time. And now about 18 years later, I think you'll agree there's a fair explosion going on in the literature of a lot of new approaches to prostate biopsy. Trying to integrate the prostate image into the biopsy scenario via fusion, via cognitive, in-bore, out-of-bore, and I have a slide that will summarize all those in a minute. I think we recognize the need for imaging in a biopsy scenario now more and more. This is a classical sort of unusual, maybe slightly unusual case, but 62-year-old man with a high PSA, biopsy positive, Gleason 3 on the left, 1 out of 5 cores. And I know all of you have seen prostate MRIs before today, but if you haven't, I hope you can appreciate the large mass on the right. As you know, TRUS is a somewhat random sampling of the gland, and it can miss lesions even as big as that, which clearly is a significant cancer. So these are the reasons why we got into this business of trying to improve the biopsies. And what we do is we do MRI first, and then the patient returns for an in-bore biopsy transperineally. We use the Siemens magnet, which is a wide bore, 70 centimeter diameter. The typical MRI is 60 centimeters. And I'm sure many of you in the audience have had an MRI at some point. Maybe it's small, it's claustrophobic, it's tight at 60. When you get to 70, it's a little easier and somewhat easier to put needles in. And so we do it transperineally, as I already mentioned, and you can go straight into the target area. And as a radiologist, it's a wonderful way for me to validate the tissue correlating to that signal. So here's a lesion at 12 o'clock on T2. Here it is on ADC. I can sample a different area, maybe the area that is the highest diffusion coefficient, the lowest. And then with the color maps of the PK, I can biopsy an area that was abnormal on the contrast enhanced as well. So you can take multiple cores from the same target and sample it carefully. And we published this in Radiology this month, and we have about 90 patients in this particular paper looking at the populations that we see. Patients with no prior diagnosis of prostate cancer, patients with a diagnosis on an AS protocol, patients with biochemical failure. And you can see the results obviously get better in the patients with known treatment, highly suspicious local disease. Anterior lesions are found very commonly, and this is all the patients in this study had at least one MRI-defined target. In the end, there were probably on average 3 or 4 targets per patient. But the anterior ones were commonly cancers, and these little circles are trying to show you the locations, benign versus malignant, malignant being the light green. We were able to look at the results based on pulse sequence alone, so the ADCs were a very high yield with an ROC of 0.8. So in the literature now, there's been some nice reviews, and this is from the UCL group, of all the biopsy approaches that are going on across the world. And just to summarize those, you're well aware, it's in-bore, it's either MR-guided and targeted, and I should have written transperineal or transrectal approaches are both being done in-bore here. And then out-of-bore, you have fusion, cognitive, you've obviously got template and saturation options as well. And so there's a lot going on. And the fusion space is very interesting and very exciting. How do you marry ultrasound and MRI together? How do we make them really work? Because that's probably, in the end of the day, the most pragmatic, most practical way to do it. Clearly, I love my MR-guided biopsy program, but it's completely impractical, I know. You all don't have, nobody has enough access to magnets to do that. But, you know, we are a research center, so we're just trying to push the envelope there. So the pragmatic thing is, how do you figure out how to take that MRI to the ultrasound so that everybody can do this and enjoy the wealth of the knowledge and helpfully guide the needles in to the targeted areas that may be segmented. And this is the sort of thing that radiologists are learning to do, is to annotate our images prior to a trust-guided biopsy so this information can be imported into a software program made by one of the many companies that are now coming out with these devices and allow for the visualization. This is how the slicer does it in the pure MR to MR registration world, where you take images acquired at different times and you fuse them together. And this fusing thing is challenging. What we're talking about really, fusion is a simple word. It really should be non-rigid registration. A non-rigid registration is when you take two soft organs, the prostate and the prostate, and you try to mold them together in accurate spatial, three-dimensional registration of everything inside that circle. And that's really challenging because the prostate is soft, it is squishy, it will move. Conditions like the probe with the ultrasound will deform, will move. And so doing this carefully and scientifically is important. And so the concept is easy to understand. It's the accuracy of these registration tools. So as you learn and as people use these devices, you will realize they're not perfect. You'll learn how to read the MR image better than you have today, and then you'll learn how to register that in ultrasound space. But I warn you, it's not easy sometimes. So this is just a visual of all of the devices that are out there. The Artemis Eigen one from the Robotics group, as you know, is a Canadian product. And then in vivo, Euronav, the one that's being published from Peter Pinto and the NIH, that nice JAMA paper that I'll show you in a minute that just came out last month. Coelis, a French company. These are just all variations of the same thing. But when you're thinking about these things, think about and ask questions about the fusion. So this is the JAMA paper, to summarize, that just came out from Peter Pinto and Peter Choiki's group. They looked at over 1,000 patients comparing MR fusion biopsies with standard truss-guided biopsies, patients with MRI target versus truss. And to try to summarize it, it's a big paper, but the targeted MR ultrasound fusion revealed 461 cancers. The truss, a little bit more, but almost the same number. They were in agreement in 69% on locations and places. Targeted versus showed more high-risk disease. So the biopsies based on the fusion systems found higher risk disease, more clinically significant disease than the truss. And the definitions are down there as to what we're talking about, what is high and low. And then the targeted found much fewer low-risk disease. So it seems to be finding the clinically significant disease that you want to treat, as opposed to the men that don't need the treatment. And so this is where Mark Emberton and Hashim and the group at UCL are proposing the introduction of MRI prior to biopsy. There's a fair number of papers showing that the target will find more accurate results and better yield, again, higher grade disease. There's multiple papers that have been coming out for years here. The added value, what does it really at the end of the day mean if we start imaging before a biopsy? We will potentially reduce the large number of biopsies that are done today. That is absolutely true. There may be unnecessary. We may get to a place where if the MRI is normal and the PSA is within reasonable low numbers, you would not do a biopsy because it has a high negative predictive value. It's pretty good. So fewer biopsies, but better treatments. Not maybe, fewer treatments obviously because we won't be over-treating the patients with 3+3. You'll be treating the patients who really need the treatment. And targeted biopsies, less false negative, better characterization, improved sampling, and a little bit less histopathology burden if we're pathologists in the room. And I'm going to skip over these in the interest of time because they somewhat repeat themselves. This is an example of an anterior tumor. And here we have a large cancer way up there. This is from the London group where you see this tiny lesion up there at 12 o'clock. That's a real challenge. How do you get your needle up there? And this is where I think transperineal is nice because you can easily get there. It's a long way for a truss needle to get there precisely. And these are the sorts of challenges that we're up against with these BPH patients. Robotics. So a lot of robotics, a lot of people developing little tools that can help and enable physicians to do things in cramped spaces. Some of these look like, I know someone's laughing, like they look like something out of a torture chamber, right? Something that Dracula or somebody had on the wall of a chamber, of a horrifying castle in Hungary somewhere. But some of these have made it into the clinic, particularly this one right here, which is the small little needle that goes in transrectally in the bore of the magnet while the patient lies prone for sampling. And this is one that's used by the Nijmegen group, the Ellie Barents, a big group in Europe. And I'm going to keep skipping over these. This is another paper that came out that's a really confusing paper in a way, but it's very interesting. It just came out from an Italian group, Piana Bianco and others. And what she did was compare the MRI imaging versus the standard of care looking at truss-guided biopsies. She did almost a randomized control trial, again over 1,000 men, divided them into two groups. One group got standard truss, the other group got the MRI first and then the biopsy. And the inclusion criteria for patients here, none of them had prior biopsies, but they all had to have all 4 of these abnormalities based on their PSA's volume. So they were really fairly tightly selected, not just a PSA over 4. So they were really looking at high suspicion of prostate cancer. And that we're not going to walk through, I promise. But to summarize her data, that particular slide, or table in the paper, I think was pretty scary. But anyway, what you can see here is, as you would expect, the truss-guided biopsy picked up a small number. The MRI pre-biopsy picked up a much larger number. If you take ones back that were negative on truss and bring them through the MRI path, because it was a crossover, you found a lot more prostate cancer as well. Interestingly, in the UK, where they manage healthcare costs extraordinarily tight, a bit similar to you and very unsimilar to us. But they have the NICE group there, which nobody thinks is really nice, but they're the group that really look after healthcare, the sort of equivalent of tech assessment group, have introduced new rules now about using MRI in their populations in the UK. The London Cancer Alliance is also adapting this. So a lot of people in Europe are really moving very quickly to that, using MRI prior to biopsy. I want to conclude with a little brief bit of focal therapy. Focal therapy, as you know, is becoming quite popular in certain areas. There's a real heterogeneity to what is focal therapy. Is it a male lumpectomy? Is it half-gland treatment? Is it a peripheral zone, a focal lesion? And then what type of therapy are we talking about? So focal therapy is a dizzying array of options. There's brachytherapy, which can be done focally. You can do dose painting or focal delivery of radiation sources like we used to do here when we were doing MRI-guided brachytherapy. The red areas being ones that we thought were cancer. We would up the dose. Excuse me, I went too fast. And then back to cryoablation, photodynamic therapy, therapy with laser, of course, and then HIFU or focused ultrasound surgery. All available for focal therapy in different places. We're doing cryo. It's a percutaneous project with transperineal, I should say, Adam Keibel and ourselves working on this together within the magnet. And I showed this one case here, patient who has had no prior therapy, had a large lesion, older man, didn't want to have surgery. And you can see again how beautifully one sees the ice ball and can determine that you have really killed the tissue using MR thermometry. And this is one of the principles of thermal therapy, is to try to get feedback on what you're doing during the procedure, so you can change and deliver the therapy in a different way. And it's a really nice, you can do this when you heat the tissue in MR-guided focused ultrasound, or you can cool it down. So this is the heating with MR-guided focused ultrasound, which we've used in uterine fibroids and people are now using in prostate. And you can see they've developed a transrectal probe that allows for the delivery of this ultrasound therapy into the prostate under MRI guidance. You can see the target, you can track the visualization of the heat, and then you can, of course, follow afterwards with gadolinium. And in a treated patient here with a significant amount of disease treated bilaterally, the non-enhancement shows you the necrotic tissue after therapy. So I want to leave you with the titillating thought that Peter Choikia and people have been talking about, and we've all been talking a little bit about, and it's somewhat controversial, but has the mammogram arrived? Is it finally available that the women are not the only ones that have a mammogram, you now have a manogram? So maybe if we can figure out the costs, I know it's an exorbitant thought, but maybe if we did a 10-minute exam, it may become cost-effective someday to be able to do screening for prostate cancer with MRI. So I want to conclude by just re-emphasizing a multi-parametric MRI. The 3 sequences are critical. PI-RADS standards are here. We in the radiology community are struggling to get those out into our reports, into our templated systems, into our PACS workstations. We need our IT colleagues to help us with that. Targeted biopsies, I believe, are here to stay. The penetration is growing daily. You hear about more and more people buying these devices and learning how to use them. And I think it's going to be a great benefit to all of us. Thank you so much for your attention.